Hello, I'm Geraldine Clarke from the Health Foundation, and this talk is about an evaluation of the impact of the Mid-Nottinghamshire Better Together Integrated Care Transformation Programme using synthetic control methods. It is joint work with Paris Parizza from the NHS England and Improvement and Arne Walters from the Health Foundation. The Mid-Nottinghamshire CCGs, which comprise Mansfield and Ashford CCG and Newark and Sherwood CCG, serve a population of approximately 330,000 ex-mining and manufacturing community with an ageing population, an increasing incidence of multi-morbidity and high levels of deprivation. The Mid-Nots Better Together Integrated Care Transformation Programme, or ITTP, was established in 2013 in response to concerns about disjointed and fragmented care and confusion about available services. They won Vanguard funding in March 2015 to continue the ITTP as a primary and acute care services vanguard, and then formed a 3-year alliance across Mid-Nottinghamshire in April 2016. Since 2019, they've been operating as part of Nottingham and Nottinghamshire Integrated Care System. So the ICTP is a multifaceted, complex intervention comprising multiple work streams. In our evaluation, we're looking at impacts on secondary care, and key interventions likely to have an impact on secondary care resource utilisation are concentrated in the proactive and urgent care and elective care work streams. So key initiatives in these areas include the local integrated care teams. These provide coordinated care for people at high risk of hospital admission through multidisciplinary teams operating across local integrated care team footprints. We've got the Self-Care Hub provided by Self-Help UK, working within the local integrated care teams to support patients around self-care and navigation to services. Then also Call for Care, which is a care navigation service providing a 2-hour crisis response, highly valued by community staff and GPs. Intensive Home Support, a multidisciplinary health and social care service operating 24/7 to bridge the gap between acute and community services and coordinated with the local integrated care team. And Single Front Door, co-located at the A&E and Primary Care Service and Kingsmill Hospital to direct patients to services appropriately. And finally, Acute Home Visiting Service, where GPs can refer patients for a visit from an acute nurse. Then finally, a programme of elective care, including referral management to standardised management of referrals and dedicated services for community review and assessment for respiratory, musculoskeletal and ophthalmological conditions. So our evaluation, what, why and how. First of all, we took a population level approach, aiming to look at the impact of all of the different components of the ICTP on hospital use for people aged over 18 years and registered with a GP practice in the Mid-Not CCGs over the 6-year period from when it started in April 2013. The aim was to provide the Vanguard with evidence to help inform the ongoing and future development of its services, part of its commitment to learning and continuous improvement. So to do this, we gathered data from GP practices in Mid-Nots and similar GP practices elsewhere in order to construct a kind of synthetic or doppelganger Mid-Nottinghamshire. That is, a Mid-Nottinghamshire where the ICTP was theoretically not introduced. We then compared its performance to the real Mid-Nottinghamshire. This is a synthetic control type method. So we collected data from April 2011 to March 2019, aggregated to monthly counts at a GP practice level for all GP practices in Mid-Nottinghamshire and in selected CCGs. We had hospital activity data from secondary care uses services data, so A&E inpatient and outpatient level records, and we used these to define outcome metrics and characteristics of patients actively seeking care. We also had publicly available data likely to impact on hospital use, so this included index of multiple deprivation, NHS digital general practice workforce, and quality and outcomes frameworks measures. We use these to define key characteristics of CCGs and GP practices and the populations they serve. So, selecting GP practices. So for the treated, we selected the GP practices in Mid-Nots that were open between April 2011 and March 2019. This left 38 GP practices. For the controls, we wanted to select similar GP practices from elsewhere in England. So to ensure similarity at CCG level, we first took the 209 CCGs in England, excluded CCGs in London, likely to be dissimilar to those in Mid-Nots, those in Nottinghamshire and those participating in the New Care Model Vanguard. Then selected approximately 70 that were most similar to Mid-Nots CCGs in the 2 years prior to the start of the ICTP. Then to ensure similarity at GP practice level, from the similar CCGs, we excluded practices not open for the whole study period, not consistently contributing to activity data or with lapses in reporting, and then selected the 500 GP practices most similar in the 2 years prior to the start of ICTP. To assess similarity, We computed the Euclidean distance between each pair of treated and control units, so either at the practice or CCG, based on key characteristics. The control units were then selected as those that were nearest to the treated units. We had to think carefully about risk adjustment, because outcomes may vary over time for reasons unrelated or indirectly related to the ICTP. By risk adjusting the outcomes for selected variables, our findings will not be affected in changes in these variables over time. So two types of risk adjustment. For outcomes where the population is at risk, the whole population is at risk, e.g. A&E attendances, emergency elective admissions or outpatient appointments, we adjust for key population characteristics, e.g. the QOF, disease prevalence and achievement scores. For outcomes where only patients using hospital services are at risk, e.g. admissions from A&E or average length of stay for admitted patients, we adjust for specific characteristics of these patients from activity data, e.g. their age, their gender and their disease severity. We used a synthetic control approach for the evaluation. The central idea is to find a weighted combination of the controls whose mean outcomes are similar to those of the treated group in the period before the programme began. Similarity is then assumed to extend into the period after the programme began, providing an estimate of what would have happened in the treated group if the programme had not been implemented. We used an extension to the original synthetic control method called the generalised synthetic control. This advances the original method by allowing for multiple treated units, and so different effects for different GP practices, and can provide more precise estimates as long as the pre-intervention period is sufficiently long. Here we had 24-month pre-intervention period. So some results. This plot shows the average number of A&E visits per 10,000 people per month for the mid-NOTS population, which is the red line, and the synthetic control, the blue line. Hence the blue line is our estimate of the average trend in A&E visits in the doppelganger mid-NOTS, where the programme has not been implemented. The difference between the two lines in the post-intervention period, that's to the right of the grey dashed line at April 2013, provides an estimate of the impact of the changes. Note that the two lines are similar by design in the pre-intervention period, and the quality of the synthetic control is measured by how closely these lines match at this time. So there were 9.7 and 14.2 more A&E visits per 10,000 people per month in the mid-NOTS population than for the synthetic control in the first 2 years of the study. Conversely, in the last 2 years, the trend reversed, and in 2018 to 19, there were 12.9 fewer visits in the mid-NOTS population in comparison with the synthetic control. Since the p-values are less than 5%, we're more than 95% confident that these findings reflect a real change in the outcomes as a result of the programme, rather than being down to chance. Not shown here, but we also looked at the over 65s, and their rates were higher for the first 4 years. So it might be reasonable to conclude that the work of the local integrated care teams, who aim to provide focused support for patients at high risk of future hospital admission, approximately 2/3 of whom are expected to be over 65, might have initially identified unmet need. This is suggested by the initial increase in A&E visits in patients aged over 65 compared to the synthetic control in 2013 as the LICT was introduced in Newark and Sherwood, and compounded further in 2014 as it was introduced in Mansfield and Ashfield. But differences in the complexity of patients attending A&E during this period may also have contributed to these increases. The lower rates of A&E visits for the adult population during the end of the study period are broadly correlated with the maturity of services attained at the entire population. So here we've got some similar results for the outcome emergency admissions per 10,000 patients per month. We can see that in 2016-17, some 3 years after the programme was introduced, there were 4 more emergency admissions per 10,000 people per month for the mid-NOTS population than for the synthetic control. After that, the programme was associated with significantly lower rates of emergency admissions, and in the last 2 years of the study, there were 5.4 and 6.7 fewer emergency admissions per 10,000 people per month for the mid-NOTS population compared to the synthetic control, respectively. We also broke that down into looking at emergency admissions for acute and chronic ambulatory care sensitive conditions. And we found that approximately 30 to 40% of the fewer emergency admissions from April 2017 onwards were attributable to fewer admissions for acute ambulatory care sensitive conditions, the remainder being attributable to non-ambulatory care sensitive conditions. In fact, we found no significant impact on the rate of emergency admissions for chronic acute care sensitive conditions during the whole study period. And then just a final look at non-zero emergency length of stay. So this is the average length of stay in days for an emergency admission where the patient was admitted for at least 1 day. And we can see that the average length of stay the average non-zero length of stay in mid-Nots population was marginally higher than for the synthetic control in the first 2 years of the programme. However, from 2015 onwards, it remained lower by an average of between 0.3 and 1 days. A reduction in the length of stay might be attributable to the investment in community services that allowed earlier discharges from the local acute trust. In particular, the decreases in length of stay are correlated with the rollout of intensive home support in the Mansfield and Ashfield regions in September 2015 and Newark and Sherwood region in January 2018. The intensive home support, or part of the LICT, is specifically aimed at reducing length of stay. So just a quick word on some of the limitations of the method. Of course, the synthetic control may not accurately capture hospital activity in mid-Nots before the ITTP or how it might have evolved afterwards. To mitigate this, we ensured similarity between the treated and control groups in the pre-intervention period, checking for quality of that synthetic control by assessing this similarity. And we also repeated with different lengths of pre-intervention periods and with different numbers of control GP practices available for making the synthetic control. Secondly, risk adjustment might not be accurately accounting for either observed or unobserved differences. We did look at analyses with and without risk adjustment. There's also a risk of bias due to innovation happening elsewhere, but we did exclude the London and the Newcombe model vanguards, and also the use of multiple GP practices for multiple CCGs might limit the individual contribution of any one area. And finally, estimates might not be capturing the full long-term effects of the individual components implemented in the later stages of the programme. So, some brief conclusions. This evaluation, spanning a whole 6 years of the Integrated Care Transformation Programme, suggests that early increases may have been driven by unmet need or more awareness as a result of the local integrated care teams, but that later decreases provide promising evidence that integrated care programmes have the potential to reduce hospital utilisation and that best results are delivered when new ways of working become embedded. Hence, it's important to be realistic about how long it takes to see results, and that early assessment risks erroneous conclusions that may lead policymakers to question or abandon potentially effective initiatives. But here, qualitative data on the underlying mechanisms of the different components, as well as perhaps a more targeted quantitative evaluation, is needed to gain a more precise understanding of how the different components acted and interacted to produce the effects observed.